You're listening to the Blood Bank Guy Essentials podcast, episode 28.
We know that in several studies that have been done, and I did one of them actually a long time ago, that about 1% of blood donors have a positive DAT. I mean, they're perfectly healthy, right? Their hemoglobins are fine. They're donating blood. You know, so that's one of those where you just say, what the DAT? I mean, that...
Thank you for that.
You're welcome. I had to work it in.
Well, hello and welcome to the Blood Bank Guy Essentials podcast. My name is Joe Chaffin and I am your host. You know, when I started this podcast in 2016, there were a few people in blood bank world that I thought, wow, if I could just get that person on the podcast, it would really, really help people. And I am so happy to tell you that I have one of those dream guests with me today. Sue Johnson is here from the Blood Center of Wisconsin, Marquette University, and the Indian Immunohematology Initiative. Sue is just a champion immunohematologist, and I have heard her speak many times over the years, and she is awesome at explaining concepts. And in fact, I've invited her here today to discuss the magical and wonderful Direct Antiglobulin test. Now, that's a test that goes by several names. I'm sure you've heard them, such as the Direct Coombs test, or just the abbreviation DAT. That's how I tend to say it, or to some, the actual acronym DAT. Anyway, whatever you call it, people learning blood banking everywhere struggle with what it is, how to use it, and really what to do with the results. So Sue is here to be your guide to understanding the DAT, and I am so incredibly honored to have her. So here we go. Here's my interview with Sue Johnson. Well, hi, Sue, and welcome to the Blood Bank Guy Essentials podcast.
Hi. Glad to be here.
Well, Sue, thank you so much for being here. I want to tell everyone about you, and I'm just warning you in advance, I'm going to brag on you just a little bit. So everyone, Sue Johnson is the Director of Clinical Education at the Blood Center of Wisconsin, and she is also the Director of the Specialist in Blood Banking program there. In fact, to tell you the truth, she is taking time away from her SBB students this morning to be with us here on the podcast. So thank you for that, Sue. Her influence and teaching efforts extend way beyond Wisconsin, as she's taught in numerous settings throughout the United States and around the world. There's a lot of things that she's done, so much that I really just have to give you the short version. I don't think Sue will mind that. Sue is a winner of the Sally Frank Memorial Award and lectureship at the AABB annual meeting a few years ago, and that honors her dedication to and her prowess in immunohematology. Sue has also served numerous roles within the AABB. In fact, she just completed a term on the AABB board. You may know her if you've ever attended the AABB annual meeting by the name Top Gun for the sessions, the Top Gun sessions that she did at the AABB annual meeting for 10 years. Wow. Well, the bottom line is that Sue, she's going to hate me saying this, but Sue's a big deal, and I am just excited beyond belief to have her with me on the podcast today. So, Sue, did I embarrass you enough there?
Yes. Good thing you can't see me right now.
Well, that is a good thing. All right. Well, so Sue, I really like to, with every guest that I have, because so many people that are listening to this podcast are people that are just getting started in our field. So I'm always curious with people that are as accomplished as you are. How did this start for you? How did you get involved in blood banking? What was it that kind of triggered your desire to be involved as a blood banker, and especially what was it that triggered your obvious love for immunohematology?
You know, that's a great question, and it actually goes back to when I was in my clinical year as a medical technologist at the time, and I had this amazing instructor who had tons of energy, tons of passion about blood banking, that when I graduated, that's what I knew I wanted to be. I wanted to be a blood banker, and I only looked for blood banking positions, actually.
Wow.
Yeah, it was crazy. But and when I graduated, there weren't so many openings like there are today. So I actually held out a little bit to be a blood banker.
That's interesting. The magic of having a passionate mentor, I think, is underappreciated, and that's really something that I hear a lot from people that enjoy what they do. Is that there at some point in their lives there was someone that really kind of spoke into it and said, you know, this is this is cool, this is fun, and that passion rubs off, doesn't it?
Yeah, it sure does. It's
Yeah.
amazing. It
Yeah.
is. And I was fortunate, over the years to, find those mentors along the way. So, and
Yeah.
maybe I sought them out a bit as well, but it's still um, definitely made a difference.
I think at this point you're serving that role for your students. That's fantastic. I mean, I mentioned to you off mic before we started this that I've heard you speak many times, and your obvious love for immunohematology just comes roaring out of everything that I've seen you do, and that's a testament to that passion that you have.
Oh, thank you.
Again, still trying to embarrass you. I'm
You
working on
are.
that. The whole red face thing. We just don't have it. I don't have the picture, but that's all right. Um, well, we're going to talk today with Sue, everyone, about a topic that is, I know, near and dear to her heart, as it is to mine. And I will tell you, by the way, Sue, that I had a similar experience. Back in my training days as a young pathologist, I had a couple of mentors at Walter Reed Army Medical Center, both in the physician side as well as the SBB side. Two SBBs that really uh, say to this day taught me most everything that I know about immunohematology, and their passion shone through as well. And this topic, the what to do with a DAT, the way you title it in when you give this presentation is who dat. I love that. Who dat? Investigating the positive DAT. The direct antiglobulin test is a test that is on its surface very simple, but there's a lot of complexities to it and a lot of what I know you want to discuss with us today is to take us through some of the details on what it means, what do we do with it, and how it all works. So the way that you break this down when you do this is into three ways, or three different objectives that summarized in a way that I just love. So we're going to do what's dat, why dat, and then at the end, who dat.
You got it.
I can't even help myself. You have to smile when you say that. So let's start at the beginning. What's DAT? What is the direct antiglobulin test, Sue?
All right. So the direct antiglobulin test is it's just an exquisitely simple test to do,
Mm-hmm.
from the point of view that we are taking red cells from a sample from the patient directly, or the donor, whoever it may be,
Mm-hmm.
and we're washing those red cells and then adding anti-IgG and anti-C3 to detect IgG and or complement binding to the patient's red cells. So it is a direct test because we're using their red cells and we're testing them with the antibody.
Okay.
Exquisitely sensitive tests, considering that the majority of DATs performed are done manually in a test tube method.
Mm-hmm.
And we know we can detect a small amount. I mean, in probably an experienced laboratory scientist's hands, down to 100 molecules of IgG. It's pretty
Wow.
amazing.
Wow. So I I don't want to leave that before we really make sure that people have a really clear picture on what you just said. So let's go over that just quickly one more time. So these are red cells that you've just taken straight from somebody's body, and all you're doing is checking to see that they have something on their surface, specifically IgG or C3.
Well, basically, however, what we do is we do take a fresh sample of the red cells right from
Mm-hmm.
the EDTA tube is the preferred sample.
Mm-hmm.
Um, and then what we'll do is we'll take a drop of cells, wash
Mm-hmm.
those 4 times with saline, and prepare a cell suspension. Wash it 4 times. You can do it 2 ways, but
Mm-hmm.
basically it's the patient red cells, washing them, and then directly adding the anti-IgG and anti-C3. It could be that it's a polyspecific anti-human globulin reagent that we use initially, meaning that it
Mm-hmm.
has both the anti-IgG and anti-C3 in it. And
Mm-hmm.
then if it's positive, we want to know, is it IgG coating the cells or complement C3 coating the cells? If
Hmm.
the poly's positive, then we're going to go ahead and test with the what we call the monospecific anti-human globulins, which are the two separate reagents,
Hmm.
anti-IgG alone and anti-C3 alone.
Okay. Okay. A couple things that pop up in that description, Sue. So you mentioned that we take those cells and we wash them. Why? What's the big deal about washing? Why do we have to wash the cells first?
So washing, basically what it'll do is remove any free antibody that might be surrounding the red cells. Because the red cells are
Uh,
always in plasma, so you know
sure.
that there'll be potentially antibody in the plasma, the same antibody that could be coating the patient's red cells. So we
Mm,
want to make sure that whatever we detect is really antibody that is actually bound to the red cell versus floating around.
I see. So if we didn't wash, would that make us at risk of a false positive or a false negative?
No, yeah. So interestingly, it's a false negative most often because the antibody would actually neutralize any free antibody would neutralize the
Mm,
anti-IgG component of the anti-human globulin reagent that we use. So it would bind to the anti-IgG that we're adding
hmm.
and give us a false negative reaction. And the
Okay.
other crucial thing in the test that is the fact that the lab scientists, when they do the testing, should be making a fresh cell suspension directly from the
Mm,
patient's sample
mm-hmm. Mm-hmm.
versus one that's been sitting on the bench top.
Right. Right. Excuse me. Okay. One other thing that pops up in your description there, you mentioned you threw out a couple of words, polyspecific and monospecific. Can we just go over that
Sure.
again for just a second? Because I think that sometimes when we're talking about antibodies, people confuse that with polyclonal and monoclonal. I've heard people struggle with that a little bit. So tell us again what you mean when you say you're using a polyspecific anti-human globulin or a monospecific anti-human globulin.
Sure. So polyspecific, and by definition, we mean it's got a combination of anti-IgG and an anti-C3. So both antibodies are in the one reagent.
Okay.
So, and then the monospecific reagent is kind of what it stands for. The mono is one, right? So it's
Right.
a separate, it's anti-IgG in one bottle,
Hmm.
anti-C3 in the second bottle.
Okay.
And
Okay.
some labs actually, it depends on your laboratory, but some labs will automatically just do the monospecific reagents
Hmm.
so that they know right away.
Mm-hmm.
But
I
traditionally,
see.
I think most labs will start with the polyspecific, and then if there's a
Right.
positive, go to the monospecific, the separate
Got it.
reagents.
So it's kind of the poly is almost you could think of it almost like as a screen.
Yeah.
If it's negative, then there's no reason to do the anti IgG or C3. Is that a fair way to put it?
Yep. Perfect.
Okay. Okay. You also mentioned that it's an exquisitely sensitive test, which is obviously super important to remember. And you said as few as like 100 molecules of IgG. That's incredible. But I want to make sure that people get this point. If the DAT is negative, that doesn't necessarily mean that there's nothing on the red cells, but there is a limit to the sensitivity of the test, right?
Correct. Correct. So there are some individuals that we define as having a DAT negative immune hemolytic anemia. So
Mm-hmm.
they have either a very low level amount of antibody that is attached to the red cells that only by using enhanced DAT methods that are we able
Mm-hmm.
to see the antibody,
Mm-hmm.
or some people have very low affinity antibody, and again we have to use an enhancement method to allow the antibody to stay on the red cell so that we can see it.
Right. Okay. Okay.
There's one other point.
Mm-hmm.
So I was just thinking, the other thing just to mention is the fact that, why is complement binding? Why are we looking
Mm-hmm.
for complement?
Sure. Yeah. Go.
So the complement binding is indirectly telling us if there, most often is indirectly telling us if there is IgM antibody present in the patient. Um,
Ah.
right now, right, we don't have the ability, nobody's been able to design an anti-IgM so that we would be
Mm-hmm.
able to directly see IgM binding patient antibody binding to the red cells. So instead,
Hmm.
we know IgM antibodies will bind complement. So, and we have good anti-C3 reagents. So if the
Hmm.
IgM antibody is able to bind complement to the red cells, and we do the DAT and add anti-C3, that anti-C3 will detect the complement binding that the IgM
Hmm.
antibody basically activated.
Okay, that's important. So it kind of, using the phrase that you used a moment ago, it's kind of an indirect way of detecting that there may be IgM around.
Exactly.
Okay. And again, just so we can be crystal clear, I'm sure that there are some people out there sitting there right now saying C3. Help us with that. What is C3?
Okay. So interestingly, I get that question a lot because it's not really, it's actually not really described very well anywhere as it applies to immunohematology. Because we all have learned the complement cascade, right? Everybody's learned that, and we've had to memorize it, and we we know its role, right? That when we get to the membrane attack complex, the C6, 6, 7, 8, 9 form the pore in the cell, and the cell bursts, right?
Hmm.
But
Right.
why it's important in immunohematology, and why C3 is the fact that when complement gets activated, we know that it starts with the C1, and
Hmm.
C1Q4 and all that. I didn't say that all right, but it gets to the
It's okay.
okay.
Nobody remembers it
No, I
anyways here, so
know
it's fine.
exactly. So so C3, okay? C3 is the point where when C3 gets deposited or attached to the red cell, it is generally cleaved into C3b and C3d. So so many actually of our anti-human globulin reagents will have anti-C3b, C3d, or just
Hmm.
anti-C3d.
Right.
So the C3d basically is telling us that an antibody bound, but it didn't cause total lysis of the red cells.
Mm-hmm.
So if it did continue, if the complement cascade did continue, the
Mm-hmm.
C3b actually is an amplification step in the complement cascade. And
I see.
then the red cells would probably get lysed and
Hmm.
not as easily detected. We wouldn't be able to detect complement as well on the cells then.
Sure. Sure. Okay, that's important. I mean, that's so. See, you're right. It is somewhat imprecisely phrased when we just say anti C3. There's more to it than just anti C3. There's different components. But if I remember right, Sue, the C3D specificity at least is what's required to get licensed as a monospecific anti C3. Is that correct, or do I have that backwards?
It's C3D.
Is it B
Yeah,
or
it is
D?
D.
Is it D?
It's got to have
That's what I.
anti-C3D.
Right. Okay. Well, so going back to the methodology, you were talking about doing this in test tubes, and that's the primary, the most certainly the classical way of doing it, right?
Right.
And are there other options? Are there other ways that this can be done?
Sure. Another common way that the direct antiglobulin test is performed is using a column agglutination method.
Okay.
Um,
Mm-hmm.
in the States, it's a gel column.
Mm-hmm.
But
Mm-hmm.
if depending on where you're listening from, there are column methods that actually have the beads, the microbeads.
Ah, yeah.
So either though are similar from the point of view that when kind of the same thing, you add the patient's red cells directly to the column. The column
Mm-hmm.
has incorporated into it anti-IgG or anti-C3. And
Mm-hmm.
then if there's IgG or complement coating the patient's red cells, the antibody in the column will
Mm-hmm.
attach and cause agglutination of the red cells. And then instead of seeing the agglutination in a test tube, the agglutination will get hung up, so the agglutinates will stay at the top of or agglutinates will form and it'll move through the gel column versus all
Mm-hmm.
the cells going to the bottom, which is considered a negative reaction.
Right, right. Okay. Are there any I mean, obviously it's a different platform and the procedure is different, but aside from that, um, are there any differences in how sensitive these tests are, or what have you seen in your practice in terms of the just is there variation between results that you might expect in a test tube versus the column?
That so at first when we first started to use gel, actually, because I've been doing this for a while, um,
Uh-huh.
I thought, oh, gel is going to be more sensitive. I mean, it just
Uh-huh.
seemed to me like, well, because with gel, you make your cell suspension. I didn't mention this. You make your cell suspension, you don't wash it. You just add the
Ah.
cells, and then
Mm-hmm.
it goes, it does its centrifugation, and you read
Mm-hmm.
it. And
Mm-hmm.
in actual fact, it isn't more sensitive. It especially again when you're in a reference lab setting, it's very similar reactivity to the test
Mm-hmm.
tubes. And in
Mm-hmm.
fact, we always run a gel column on DAT negative hemolytic anemia evaluations and looking at what others have done. It doesn't seem, I mean, there are cases where sometimes the gel will be positive, but
Mm-hmm.
then there's sometimes cases where the tube's positive and the gel's
Right.
negative.
Right.
So I I don't think there's overall
Yeah.
sensitivity improvement with one method over the other, actually.
It's
I think it
interesting.
really,
That's interesting.
yeah, I really thought it would be more sensitive, but I don't think it.
Well, and that kind of goes to some conversations that I have with people a lot of times about the various testing platforms, and that to go away from DAT, but just people talking about, you know, gel versus solid phase versus tubes and PEG, et cetera. And what I always tell people, and I would love your take on this, is that they all have their strengths and weaknesses, and there's no perfect platform. There's always potential holes in every platform. Is that a fair way to put that?
Absolutely. I totally agree with you on that. I mean, I always say, if there was one method that was highly sensitive and specific, we would all use it, right? I mean, and it's not there. We don't have it.
Well, and so forgive me, that was a little bit of a sidelight, but I get that question a lot, so I just wanted to make sure I got your take on it. So before we move on into why people might have a positive DAT, you can probably tell, Sue, I'm a total immunohematology nerd. I love the techniques, and it makes me happy. So I want to just, before we leave the technique, let's go back to tube testing of DAT for just a second,
Sure.
and um, help me understand where the potential pitfalls are. Where are, as in your experience, and you've taught this for a long time, where are the things that people might mess up, and how do we figure out that we've messed up in those settings?
Sure. Okay. So, like I said, the DAT is such a simple test to do,
Mm-hmm.
but there's a couple points that are really important. First thing is that when we start to do the test, we get a fresh drop of red cells
Mm-hmm.
directly from the patient sample from the EDTA tube. The reason is, I didn't say this before, but the reason is when if you've already made a cell suspension and those cells are sitting in saline, we know that a weak positive DAT, where there's just weak binding of IgG antibody,
Mm-hmm.
especially IgG, just by it sitting in saline, the antibody can come off the red cells, and
Uh,
so you'll get a false negative,
mm-hmm.
right? So first thing, make sure it's a fresh drop of cells from the patient sample.
Mm-hmm.
It doesn't take that long. Just a quick
Yep.
get the cells, make your cell suspension, then start washing.
Mm-hmm.
And the washing in a test tube method should be uninterrupted washing.
Right.
So, I mean, if we have to wash manually, it should be, you know, centrifuge is done,
Mm-hmm.
decant the saline, fill it up again, and just keep that process going. Because again, if the red cells sit on saline at all, then that antibody, or if it's a low affinity type antibody, the antibody is going to come off the cells.
Mm-hmm.
Um, if it's in a cell washer, it shouldn't be interrupted. Then
Mm-hmm.
the key point there is that as soon as it's done washing, you add your antihemoglobulin reagent, your polyspecific or your monospecific reagents.
Mm-hmm.
Um, I mean, I've seen it. I've seen, you get interrupted, you have to go issue blood,
Sure.
phone rings,
Mm-hmm.
and the tubes sit there for a while. I
Mm-hmm.
mean, that's not good practice for any test tube method, but especially a DAT. They
Mm-hmm.
shouldn't sit. So, and then read immediately.
Yep.
So it's mostly about worrying about false negatives.
Gotcha. Gotcha. So one and that's those are awesome tips. I love that. One thing that people I think probably more on the physician trainee side than the lab scientist trainee side struggle with is the whole concept of the so-called Coombs control or the check cells. Can you talk us through what that means?
Sure. So the Coombs control cells or the check cells, they're either cells that are IgG coded
Hmm.
or complement coded cells. And what we're doing there is when we have a negative reaction, we want
Hmm.
to ensure that the the anti-human globulin reagent that we've added is working.
Hmm.
So if there's a negative, we don't know for sure
Hmm.
until we add those cells that we know are coded with IgG or complement.
Hmm.
So when we add the IgG coded red cells, then we're adding that to the test. We
Hmm.
centrifuge it again, and then the anti-human globulin, the anti-IgG that's present in the test, will bind to those check cells
Got it.
and or IgG coded cells, whatever we call them, right? Coombs control cells. We call them check cells. That's why I keep saying that. Okay.
No problem.
Okay. So we when we add those, the
Uh-huh.
anti-IgG will bind. That will give us a positive reaction, and it's usually, a 1 to 3 plus positive reaction, but it's a
Hmm.
positive reaction. Same thing for the anti-C3. If we have anti-C3 alone in our test, we're going to add complement coated cells
Hmm.
and to any negative reaction because there was no complement coating the patient red cells.
Hmm.
We have to make sure that anti-C3 is working, so we add complement coated cells to the test, add those right in,
Hmm.
centrifuge, and again, then the anti-C3 should bind to the complement coated cells. Again,
Got it.
proving that it's working.
So we've talked about the mechanics. So let's go to why this happens. What's the cause of a positive DAT? What are some of the possibilities for things that could give us either IgG or C3 on a red cell?
All right, so why dat? we're we're uh, we're going on. So what's the cause, right? The
Hmm.
cause of a DAT. So we know, right, there are different reasons why antibody or complement coating of the red cells can occur. We know a patient could have an alloantibody,
Hmm.
and that antibody, of course, is not going to attach to their own red cells because by definition the patient is antigen negative. They've
Hmm.
made the antibody, it's alloantibody, but that
Hmm.
antibody can bind to transfused red cells. So
Hmm.
the antibody will cause a positive DAT when we test the patient because we're detecting that antibody attached to the transfusion or the transfused foreign red cells.
Hmm.
We'll have a positive DAT when a mom has an antibody that is directed against antigens on her baby's red cells,
Hmm.
on the fetal red cells. A positive DAT will also occur when we have a patient that has the autoantibody. And I think that's probably the one that we all think about right away and we've all learned
Sure.
about,
Hmm.
right? That antibody is positive with the auto control. It's positive with the cause. It's causes a positive DAT because the antibody is against yourself.
Hmm.
And so it makes sense that the
Sure.
DAT is positive. Um, Drug-dependent antibodies definitely
Mm.
will cause a positive DAT. There, it's because the drug that the patient is taking, they've made an antibody to the drug or to some component or element of the drug that creates this new antigen
Hmm.
with the red cells. So that antibody can then coat or attach to the patient's red cells because the drug is present.
Right.
And then there's some non-immune causes, ones that we probably don't really understand, where there's non-specific binding of antibody that we aren't able to say what causes it, but it might be hypergammaglobulinemia, some
Hmm.
other situation that's going on in the patient. Um, and then the last one I think about is passive antibody, where the patient is receiving maybe ABO um, platelets that are not their own type, right?
Oh,
Like
okay.
a patient that's receiving O platelets, for
Hmm.
example. or maybe intravenous gamma globulin. I mean, patients that get that, they're just basically getting a bag of antibodies.
Right,
So,
right.
so and who knows what could coat the patient's red cells
Of course.
from a bag of from a IVIG treatment. So there's lots of reasons for positive DATs, and then the last, like I said, is there's patients that just have a positive DAT, and we don't know the reason. I mean, clinically, it's hard to know why it's positive.
I think that's a hugely important point, Sue, and I think we need to emphasize that simply because that I think I'm not sure that that's completely understood, and I know you have some statistics for how many people just kind of are walking around or in the hospital just that have positive DATs that don't mean anything. Can you talk about that for just a second?
Sure. So we know that, for example, in blood donors,
Mm-hmm.
we know that in several studies that have been done, and I did one of them actually a long time ago, that about 1% of blood donors have a positive DAT. I mean,
Yeah.
they're perfectly healthy, right? Their
Yeah.
hemoglobins are fine, they're donating blood,
Uh-huh.
so that's one of those where you just say, what the DAT? I mean, that.
Thank you for that.
You're welcome. I had to work it in.
You had to.
Um, so, those are just who knows why. I mean, and the DATs can be 1 plus, and I've seen 4 plus positive
Wow.
DATs in normal, healthy blood donors.
Mm-hmm. Mm-hmm.
Um, and then if we look at the patient population, different patient groups have been studied, but it's up to, 15% of patients with, for
Wow.
example, sickle cell or thalassemia in the chronic
Mm-hmm.
transfusion state that will have positive DATs that clinically don't seem important, at least not that
Right.
we can, put a, definite,
Mm-hmm.
attribution to causing trouble in the patient.
Yeah.
So yeah, there's a lot. I mean, we used to do, I mean, in my lifetime of blood banking, we used to do auto controls all the time.
Uh-huh.
And what we found was that we were doing a lot of work for
Uh-huh.
no apparently good reason for the patient.
Sure. Sure. Yeah.
Right?
Tracking down stuff that just doesn't mean anything.
Exactly. Exactly.
Yeah. But I think that's a really, really important point because you took us through the causes of a positive DAT, like an alloantibody, an antibody, a red cell antibody against someone else's antigens, autoantibodies against your own red cell antigens, a maternal antibody against baby red cells, drug dependence, non-specifics, and passive antibodies like with out of group platelets and IVIG. So that kind of brings us to the next point: is why should people do DATs? And I think it kind of goes to what we just talked about, right? In terms of what the causes are.
Right. I mean, so the reason for doing the DAT, right, is that it helps you explain something that's going on in the patient. I mean, as an immunohematologist too, like loving this stuff, right, is
Mm-hmm.
um, we do a lot of testing on antibodies, right? We're
Right.
working mostly on antibodies and making sure that we're getting the right blood to the right patient, providing
Sure.
antigen negative. But a direct antiglobulin test, the result can be diagnostic. I mean,
Mm-hmm.
there in all these situations, right? Almost all of them that I talked about, it's telling us something about the patient that might not have been known yet.
Mm-hmm.
That they could have a drug-induced hemolytic anemia. Of course, I love that. But
Mm-hmm.
it could be a transfusion reaction. It
Sure.
could be HTFN, right? So
Mm-hmm.
it is
Mm-hmm.
super important. And I've had clinicians tell me when we've evaluated those DAT negative patients
Mm-hmm.
where, the patients had all the signs and symptoms of hemolysis and they haven't been able to tell the patient there's a positive test result.
Mm-hmm.
And they said this means all the difference because now I can tell them I have a positive.
Right. Right.
So I
Right.
was like, wow, oh, that
Yeah.
I see it.
Absolutely. So it can kind of give the answer where one wasn't present before, and that's that for us in blood bank world. That's a little bit of a unique experience, isn't it?
It is. It is. It's actually really cool when you can do that.
I like it. I like it. So again, let's just talk through the settings. You had mentioned acute transfusion reaction investigations.
Right.
what other kind of things might be going on clinically that might trigger either a doc to order a DAT or a transfusion service or reference lab to say, I need to do a DAT.
Okay, so, well, right, the transfusion reaction, absolutely, in acute
Mm-hmm.
transfusion reaction setting. The other place that's common that doesn't usually get ordered by a doc, but is in the end will be is in the case of delayed transfusion reactions,
Ah.
and
Mm-hmm.
those are generally where the patient comes in. They got blood 2 weeks ago, and their hemoglobin's back down,
Mm-hmm.
and so the order comes to the lab for 2 units or 1 unit,
Right.
whatever,
Right.
and you do the workup, and now you find there's a new antibody present.
Got it.
And the antibody you identify, you find the auto control and or the DAT are both positive. Depends on how somebody approaches the workup. But you
Mm-hmm.
see a new antibody, generally you do a direct antiglobulin test, and you find positive result. Another scenario would be in those patients that are showing signs and symptoms of hemolysis. Hemoglobin, of course, is down. The LDH is elevated,
Mm-hmm.
spherocytes on the smear, bilirubin's elevated, all the other lab tests are pointing to it. Those are generally more physician ordered.
Right.
Hematologists that'll order, I put in quotes, the Coombs panel.
Ah, yes, of course. Of course.
Which we all know means
Mm-hmm.
a direct and indirect antiglobulin test, or they call it a
Mm-hmm.
Coombs direct and indirect.
Right.
Um,
Right.
but that in that case, then those are physician ordered tests, right? That
Mm-hmm.
we're doing, and that truly is. They're looking for something to occur,
Mm-hmm.
or for a reason for the what looks like hemolysis. Um, and then again, like the same thing would be for a drug-induced case. Generally, it's either
Mm-hmm.
that they're ordering blood because their hemoglobin is down to 5,
Mm-hmm.
or they are seeing these signs and symptoms of hemolysis. However,
Got it.
but oftentimes actually the hemolysis is so brisk that they're ordering blood and then trying to figure out what's going on.
Mm-hmm.
So
Right. That's certainly true.
yeah.
Um, the one other thing, and forgive me, I'm interrupting, but I'm just jumping ahead just a little bit in terms of when a transfusion service or reference lab might do it in a maybe in an antibody identification workup, when what might trigger a transfusion service to kind of automatically order or do a DAT.
So I definitely, if you're running, say for example, your routine antibody detection method is solid phase,
Mm-hmm.
then usually when you have a positive antibody screen or you detect an antibody, you go on to do a panel. You
Mm-hmm.
can't run an auto control. Well, you can, but
Mm-hmm.
it's very tedious, and
Mm-hmm.
um, most people don't do that manually.
Mm-hmm.
They will go automatically to a DAT. In a case where labs are using gel or tube testing, they might do a DAT automatically when they get a positive antibody screen again.
Mm-hmm.
Or they see an antibody, run an auto control, also then do a DAT. So um, those would be the scenarios generally. And
Okay.
then I guess I didn't mention babies, cord
Ah,
blood.
yes.
I
Mm-hmm.
forgot it
Good.
to mention
Ah,
cord
yes.
blood. Yes. Um, and then everybody's got slightly different rules on when they do they'll do a DAT on a cord blood, but that would be the other scenario, right? And that's generally
Sure.
um, written within the standard guidelines, right, for the hospital
Yep.
on
Yep.
which babies they'll evaluate.
Right. Okay. Well, and so speaking of that, in terms of evaluating this, and I don't want to leave this point before we make this point crystal clear to people, and that's simply this: context matters with the DAT. It matters why it's being ordered. It's extraordinarily important in helping clinicians to understand what it means. You got to know why it's ordered, and that's me on my soapbox for a second, Sue. But I know you feel the same way
Oh,
about that.
definitely. I mean, when we get that positive test result in the lab, if we don't know history, we don't know what it means. right?
Exactly.
We
Exactly.
we have to get the patient history. What's their age? I mean, that tells you a ton right there,
Mhm.
right?
Mhm. Mhm.
Yeah, all those things, super, super important.
Okay. Well, so with that being said, let's get to how we look at the results, because I love the way you look at this. You have you say some things, and especially in terms of the interpretation of strength, that I haven't heard a lot of other people saying. So I want to make sure that we get to that.
Okay.
So let's talk through this. So we've got someone has a DAT ordered for whatever reason, and we do the test, and we get back some results. How do you go about analyzing those results to kind of help point you in the right direction to see what they mean?
Okay. Well, first thing we look at is what's the strength of reactivity? Because, a positive is not a positive, right? I mean, to me, looking at what the strength is and then considering that in the context of the patient um, tells you the story. Almost always. Almost always. So if we look at what's positive, of course, right away. So if the polyspecific is positive, we automatically will go to the monospecific reagents, the anti-C3, anti-IgG. If only complements on the red cells, then that's putting me in a whole different direction, right? Of thinking about what could be on the red cells. So if it's a weak positive with complement only, and I know my patient just was transfused, just like currently or 14 days ago, I'm thinking a transfusion reaction. Could be acute or delayed depending on the timing, because I wouldn't expect to see a weak complement only um, with a cold agglutinin disease, for example. So if I compare that then, right, if I have a stronger positive C3 on the cells, so a 2 to 4 plus, they usually aren't 4 plus, but they could be. It's usually more in the 2 to 3 plus range. I think that's because of the avidity of the antibody and how much complement gets bound to the red cells. However, if it is stronger, then I'm thinking more, and there's no history of transfusion, I'm absolutely thinking more drugs, cold agglutinin disease, or PCH, paroxysmal cold hemoglobinuria. If there's IgG only on the cells, again, the strength. Um, if it's a 1 plus or less, then, and kind of have to know how your techs, you know, shake a test too as well. But
Mm-hmm.
um, if 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 I'm confident that that's a 1 plus or less, then again, I'm thinking it's more likely transfusion reaction, maybe passive acquired antibody, or if it's an infant, a cord blood, maybe more AVO-HDFN. If the DAT is stronger, and I usually say 2 to 4 plus positive, and you could even argue again, depending on how skilled your laboratory scientists are, but if there's stronger positives, I'm thinking again, warm auto, drugs, and if it's again the case of a cord blood, I'm thinking more of RH, hemolytic disease of the fetus and newborn, or one of the other types, right? But RH most commonly. Again, because weaker positive, that's telling me the antibody is only binding to a smaller amount of red cells, or there isn't as much antibody, right? And that's why I would think of a transfusion reaction. It's only binding to the transfused red cells.
Mm-hmm.
Strong positive, well, that autoantibody is binding to all my red cells. I should expect to see a strong positive. Same thing with RH and anti-D crossing the placenta, binding to baby's RHD positive red cells. It should be strong. And then finally, if I see both IgG and complement, I kind of use the same rule. Weaker positive, more likely, and there's a history of transfusion, I'm thinking transfusion reaction. Strong positive, I'm thinking drugs or warm auto.
So that Sue, that is such a cool way of looking at these things, and I know that you and a couple of your SBB students put together a chart about this, or a flow chart of kind of a diagram that you have been kind enough to allow me to post on the website. So everyone, what Sue just talked about is such a really helpful way of looking at your results, and when fitting it together with the context, you can point yourself in the right direction really well. So that's great, Sue. Thank you for going through that.
Oh, no problem.
Okay, so we've got all these possibilities, and we now know that it's essential to understand why it's being ordered. We know that it's essential, once you know how it's being ordered, what the context is, to take a look at the what's positive on the test, what the strength is on the test, and how all that works together. So I guess once you get through all that, and once you get a positive DAT, and you're kind of pointing that in the right direction, how do you give feedback to your ordering docs about what this means? Does this mean a direct conversation? Do you just put out a report and yay, everybody's happy? How do you feel about that interaction?
That's a great question. I'm fortunate that I work with board certified transfusion medicine
Mm-hmm.
physicians that feel very comfortable,
Mm-hmm.
and actually want to be notified whenever there's a new positive DAT
Right.
for that reason, right? So that they can communicate, or we can communicate, right, the results.
Yep.
So generally the results would get communicated,
Mm-hmm.
right away.
Mm-hmm.
And then from our hospital transfusion service perspective, then our physicians would then go ahead and, follow up, make a note, talk to the doc, whatever it might be.
Mm-hmm.
But I know a lot of times the results are just issued,
Right.
right? And however, like from a reference lab perspective, or even in the transfusion service, whenever you have a new positive DAT, that patient history is so important for that context so that you can evaluate. Otherwise, all you can report is the DAT is positive due to IgG,
Mm-hmm.
or the DAT is positive due to complement. But if we have history, then we can say, well, because the patient was transfused, these results are consistent with,
Right.
right, a
Right.
transfusion reaction or what have you. So I think it depends on who you work with, but absolutely should be communicated.
Yeah. Well, so before we go on to do just a couple of quick cases, Sue, I wanted to throw a couple things at you, because people ask us about these things. The first one is this. Okay, so you've got a positive DAT, you got a positive DAT with IgG, and let's say it's in the setting of a transfusion reaction workup or an autoantibody or something like that. Is there a way, and I'm guessing there is there a way for us to determine what the heck that antibody is that's coating the red cells?
Oh, absolutely.
Boy, that's a softball
I
right
know.
there, right?
So absolutely, and I was so focused on the DAT, right? But yeah, the what we can do when we have that positive direct antiglobulin test, especially with IgG, but I would not deter either, depending on the context again,
Mm-hmm.
with only complement on the cells, that we can determine we can get a good idea of what's coating the red cells by doing an elution method,
Mm-hmm.
right? So, and if we do an elution, we can most commonly today we can treat the red cells with acid,
Mm-hmm.
which is a low pH, like pH 3.5, and if we add acid to red cells, the antibody does not like that. The
Mm-hmm.
antibody will come off the red cells. We buffer it back to normal so that we can then test what's now called the eluate. So we add the acid, the antibody comes off into the supernatant,
Mm-hmm.
that's the eluate.
Mm-hmm.
We can't use that yet. We have to buffer it back to a normal pH so we can test it
Mm-hmm.
with normal red cells. So we add a buffering solution back, and then we can take that eluate that we just made, which is the antibody that should have come off the patient's red cells.
Mm-hmm.
We can test that then against a panel of red cells, like we would do any antibody identification,
Right.
and determine what's coating the red cells. So is
Nice.
there a single antibody?
Mm-hmm.
Is it an antibody that's reacting with everything?
Mm-hmm.
And then that helps us put the story together.
Mm-hmm.
If it's a 4 plus DAT, I would expect to see the eluate reacting strongly positive with everything,
Mm-hmm.
consistent with warm autoantibody.
Nice. Okay. Okay, so and because I know that there are some people out there that are sitting there going, okay, people often use these words together. They talk about elutions and they talk about adsorptions, and my goodness, I can't remember what the difference is. I know this is going off on a little bit of a tangent, but just help everyone understand real quickly what's the difference between an elution and an adsorption.
So an elution, right? Think of it this way: you're eluting off, so you're pulling
Mm-hmm.
antibody off the red cells.
Mm-hmm.
Whereas an adsorption is we're taking antibody, usually known antibody. We have something that is in the plasma that we
Mm-hmm.
want to remove from the plasma. So we're going to take it, we're going to do an adsorption. So we're going to take the plasma, mix it with some red cells, other red cells or patient's own red cells,
Mm-hmm.
and the antibody will adsorb from the plasma onto the red cells. So
Mm-hmm.
an elution is pulling antibody off, and adsorption is taking antibody from the plasma and putting it onto red cells.
Okay, so we just have a few minutes left, and I wanted to just kind of put some traction to this, and just hit you with just a few quick clinical scenarios, kind of the who dat
Okay.
section here, and just quick hitters. Just kind of tell me how you would approach situations like this. Okay, so here's the first one. We've got a you're working in the blood bank, and you get a call from a clinician who says, hey, I have this patient. Doesn't give you a lot of info. He says, I have this patient that I really need to order a direct and indirect Coombs on, and I the patient was just transferred from another hospital, and I have these results that are like, he's got 1+ poly, 1+ IgG. I don't know what any of that means, but I know that I need a direct and indirect Coombs. What do you do?
Okay. So in that case, right, so he knows, or what we know, is that it looks like the patient has an antibody, an IgG
Mm-hmm.
antibody bound to the red cells. That's all
Mm-hmm.
we know in this context, right?
Mm-hmm.
We, so what I would say is, well, if he wants it done here, we probably need to do it in our lab. So we
Mm-hmm.
would do the direct again, look at
Mm-hmm.
that. We would probably do an eluate, depending
Mm-hmm.
on what the clinical situation is. So then
Right.
it might be, well, do you have any results yet? Do you have a bilirubin, LDH, anything like that?
Mm-hmm.
Do you have a transfusion history? What's the patient's diagnosis, right? All of those things again, because like I can't tell much other than the fact that the patient has 1+ positive DAT, and it might
Mm-hmm.
not be important at all
Right.
because we know up to 15% of people can have a positive DAT.
Yep. Yep. Okay. Okay. Awesome. Okay. That's number one. Like I said, quick hitters. Number two, you've got a patient who's a 45-year-old female with acute myelogenous leukemia who's getting a transfusion of red cells and has a fever during the transfusion. So, as part of the transfusion reaction workup, everything initially looks fine. There's no clerical errors. All the paperwork checks out. There's no hemoglobin when you spin down the post transfusion sample. But when they do the DAT on that post transfusion sample, they see a 2+ poly. That's all the information you have. What do you do with that?
Well, first thing is remain calm.
Yes. Take your own pulse, right? Yeah.
Yes, exactly. Because most often everybody gets a little freaked out when the DAT is positive. Either that or you see
Right.
hemolysis, one or the other, right?
Mm-hmm.
Then the most important thing at that point is to go ahead and then get a pre-transfusion sample. Because again, that patient could have had a positive DAT before they received that unit of blood. And then really assess at that point, right? Is if the pre is
Right.
positive, then there's really not much more. Um,
Mm-hmm.
I mean, you could do more work, but like eluates and things like that to get a handle on it. But for the transfusion reaction investigation, you can't, you aren't going to be able to tell a whole lot more if both the pre and the post are positive.
Good, and I see that question a lot, and it's important for people to understand that it should be reflex, right? It should be automatic. You
Yep.
see that positive post, you gotta do the pre. One other question related to that, though, that sometimes people ask me, and they say, okay, well, they were both positive. The pre was positive and the post was positive, but the pre was 1+ and the post is 2+. Should I freak out?
That's a hard one. Because in most labs, right, if you if you check you, if you did like gave the same, say, set of dilutions to all the
Mm-hmm.
laboratory scientists in your lab and
Mm-hmm.
had them test the same red cells, even in the best of labs, I would say you always have a plus or minus one reaction grade between the
Mm-hmm.
techs.
Mm-hmm.
So it's difficult to know one. I mean, hopefully
Mm-hmm.
it's the same tech that did the pre and the post, but if not, even the variability between in the test, that still could happen.
Yeah.
So that's still within the normal range to me,
Right.
of
Right.
not a significant change. Um, However, I mean, if I felt really good about it and it was a 1 to a 2, I would probably go ahead and do an eluate
Mm-hmm.
and just compare the eluate on the pre with the post. Again,
It's
see,
reasonable.
yeah, pull antibody off the cells, see what you have.
Mm-hmm. And certainly, if it's 1 plus to 4 plus, which I mean, you've already talked about in the setting of a transfusion reaction, that's unlikely. But if you did have a substantial change like that, that's obvious that you got some more
Yeah,
work to do. But
absolutely.
the big kicker that we're looking for is the negative to positive, though. That's
Right.
that's the flag.
That
Okay.
is the flag.
All right, so that's the second one. How about the third one? So we've got a 72-year-old male who's admitted with a sky high white count, primarily mature lymphocytes on that white count, and he is showing, well, he's anemic, and when the chemistry, I'm sorry, when the hematology section of the lab spins down his sample, they say, "Wow, his serum really looks yellow. What is the deal with this?" And someone orders a DAT and it's 4 plus poly, 4 plus IgG, and 2 plus C3. What kind of things might we be thinking about in that scenario?
So in that scenario, so it's a perfect setup. That's a lot of great information.
Hmm.
One, I'd be
More than we
looking
usually
at
get, right?
more exactly.
Sorry, I made it too easy.
No, you did well. And actually, I was laughing to myself when you said anemic because I can tell you, being in a reference lab, I, I would say half the recs come in with the diagnosis of anemia.
Yes, you're right. You're right about that.
And you're always like, okay, come on.
Yeah, really. Give me more.
Yes. So CLL. First thing I think of is, and with a strong positive DAT, I'm thinking a patient with a warm auto antibody. We know that warm auto is not uncommon, secondarily seen to CLL patients. Um, the strength of the positive DAT being 4 plus, complement positive, very again consistent with a warm auto. Um, and the fact that you told me the plasma was yellowish would make me think more warm auto. If it was reddish, then I actually, and it was a patient with a hemoglobin of 4, I would have been thinking more a drug case, drug-induced hemolytic anemia. Um, but yeah, I've done this. I walked into the lab and said, "Can I see a sample that has a warm auto?" They look pretty normal. Like they're just yellowish. Um, but that strong positive DAT that's the key thing.
Okay,
Sounds
got
like
it.
war motto.
So we have taken a kind of a grand tour through the wonderful world of the direct antiglobulin test, and Sue, you have been a magnificent tour guide. I can't tell you how much I appreciate you doing this. Is there anything before we go? Any last tips that you would give to people that are uh, learning about the DAT, trying to understand the DAT? Any last thoughts to leave us with?
Oh, I mean, just the thing about the direct antiglobulin test is the fact that remembering that we're looking at patient red cells.
Hmm.
And remembering that is oftentimes not just their red cells, right? That there could be transfused red cells there as well,
Yeah.
or even, I guess, baby red cells, but that would be a lot. Um,
Hmm.
that it is patient side of the world, it's the patient red cells versus plasma, right? Because normally we're looking at the antibodies in the plasma, in the serum. Um, and I guess the other thing is, again, when we're interpreting those results, like I think we've hit on a lot, is
Hmm.
that we look to see that what's the context, what's the patient history, everything around that, and then the strength of reactivity. Because if you have all that, you can
Mhm.
really do a great job at interpreting the results and providing that information to the patient or to the patient's physician. So usually, like we've talked about that, right? What's dat, why dat, who dat,
Mhm.
and so I always say you got to end with we love dat.
Ah, yes. Yes, we do. Well, Sue, you are awesome. Thank you so very much for doing this. I can't tell you how much I appreciate
Oh, you're very welcome. Tons of fun. Hope
it.
everybody finds it helpful.
I'm sure they will. We'll talk to you soon. Sometimes I think that when you get to talk with someone that you really admire, that you feel disappointed afterwards. It's kind of the whole hero thing. Then you find out that your hero is not really all that great. Well, let me just say that that is not how I feel after talking to Sue today. I learn from her every time I hear her speak, and today was absolutely no exception. Um, I hope that you enjoyed it. I know I did. I should tell you that when you look on the show page, that's on bbguide.org/podcast, and you'll find this episode. I've included not only a bunch of slide images that Sue has generously provided, but also a link to a series of videos that Sue did on the Indian Immunohematology Initiative website, where she's actually performing the DAT. You actually get to watch her performing a tube DAT, as well as a bunch of other basic immunohematology tests. And the videos are great, and I think you'll learn a lot more by watching them. So, my thanks to Sue Johnson for appearing on the podcast. My thanks to all of you for listening and downloading the podcast. And, just thanks for inviting me along in your journey toward mastery of blood banking. Please head on over to bbguide.org/subscribe and get on my email list so that you won't miss any of the cool stuff that's coming down the line. And also, the next time you're near a computer, please just head on over to iTunes and give this podcast a rating and a review, because it really helps others find it, see it, learn from it too. So that is it for today. Thanks again, as always. And as we close, I hope that as you go through your day, that you'll smile and have fun. And above all, hey, never, ever stop learning. Thanks a lot. We'll catch you next time on the podcast.